Good morning, everyone, and welcome to UKCFC 2023. I'm Katherine Cowan. I'm an independent facilitator, and I'm going to be guiding you through your agenda today. This is the second time we've done a hybrid UKCFC, so whether you're here in the room with me in London or if you're joining us virtually from wherever you are in the world, thank you so much for taking the time to be part of this. We're really pleased to have you here for what I think is going to be a really interesting and hopefully very enjoyable day. Very shortly, I'll be introducing David Ramsden, who will give us the official welcome. But before I do that, there are just a few things I'm going to run through. I want to talk you through how the day is going to run, and then I'll cover a little bit of housekeeping, both for those of you here in the room and for those of you watching online. So in terms of format, the day is split into 4 sessions. We've got 2 sessions this morning. Those are separated by a coffee break at 11:45, that's UK time. There is a small change to the agenda. So the poster viewing session has been brought forward to the lunch break, and that's in case anyone needs to leave early because of the impending train strikes tomorrow here in the UK. And the poster judging will also take place at lunchtime. The winners of the poster competition will be announced at the end of the final session. Session 3 is after lunch, that's at 2:30, that will be followed by another break, and then session 4 is the final session, that starts at 4:15. That's going to be followed by a drinks reception in the foyer from 6 to 7:30, that's for those of you here, if you don't need to head off early. So that's the format. There's a little bit of housekeeping that I need to run through. So I'm going to start with the housekeeping for those of you here in the room, and then I'll come on to housekeeping for those of you online. So first of all, if you're here, the Wi-Fi code, if you don't know already, is Wi-Fi, that's all lowercase, 7103. So Wi-Fi 7103. You've got tea, coffee, and refreshments available all day out. There's various machines in the foyer just immediately outside this room. And outside the room, you'll also see the sponsors. There's also the research table, the posters, and the staff will be there as well if you have any questions. We're not expecting the fire alarm to go off. If it does, then it's the real thing. Just follow the exit signs, and the staff will come and guide us, but there's exits on the left and the right. We assemble outside. And if that does happen, then online audience, just please bear with us. If you want to look at the agenda at any point, there's a QR code on your tables, and just use the camera on your phone to scan that, and that will take you to the agenda. You can also ask, we'll have a couple of opportunities to ask questions of speakers, so that'll be at the end of sessions 2, 3, and 4. At that point, do raise your hand if you have a question. I've got a prop. We have this microphone catch box, which we can throw around the room. As I'm looking out, I was so rubbish at netball at school, I'm not even sure it's even going to get to the first row, but we'll do our best. I've been told it's indestructible. I don't think it'll hurt if it hits you in the head, so I haven't tested that yet. I'm definitely seeing a lot of water bottles that could go over, so maybe it'll be more of a pass the parcel. But don't worry, we've also got roving mics, so we'll figure that out as we go along. And if you also do have access to the conference platform, so if you'd rather ask a question that way, then you've got that opportunity. You'll notice that we have a photographer and videographer here. They'll be taking photos and footage throughout the day. Hopefully, if you didn't want to be filmed or photographed, you've already let the team on the reception desk know. If not, just tell them and we'll make sure that you're not captured. So I think that's everything for everyone here in the room. So online audience, I'm coming to you next. We've got some housekeeping messages for you. So you're currently watching from the conference platform where you have access to a number of tabs. So there's the resources tab. And if you go in there, there's lots of information, useful stuff for you to download. Also, importantly, there's the posters tab, and that means that you can view the posters that our early career researchers will be presenting today. If you scroll down your screen slightly, you'll see the Slido box, and you can use that to submit any questions that you have for the speakers. It's always helpful if you can indicate in your question who the question is for, and you can tick to make it anonymous, or you can have your name on there. Within that box, you'll also be able to see all of the questions that have been submitted. And actually, everyone in the room, if you go on the conference platform, you can see those questions too, and you can vote for them. We'll ask the most popular questions. And again, if you scan the QR code on your table, you'll be able to get that. If you've got the Slido app, you can just put the code in. I will come back to Slido in a minute, because we're going to do a couple of polls just to find out a bit more about you. So a couple more things for the virtual audience. The conference agenda is on the right-hand side of your screen. And at the bottom of your screen, if you scroll down, there's a yellow speech bubble. It's basically a chat box. And we're using that. If you open it up, we'll use that as a sort of, the intention is for it to be a kind of online delegate networking feature. I'd really like to encourage you to post comments and reflections in there. I know that when you're attending a conference online, the main thing that you miss out on is the opportunity to chat and to interact, to make contacts, to network with people. So I hope that this will go some way to enabling you to do that. I hope you'll enjoy it and that it'll be useful for you. Finally, if you're online, if you have any technical issues, then click the support button at the bottom of the page, or you can email conference@cysticfibrosis.org.uk and one of the team will help you out. So that's the housekeeping taken care of. I'm going to come back to Slido now, and we've got a couple of polls to find out a bit more about you. So online delegates, you can scan the code, or I think we've got it up here on the screen. So if you scan that, that'll enable you to take part. Online delegates, scroll down to see the Slido. And basically, we're going to be asking you, where are you joining us from, and what is your relationship to CF? So while you're doing that, I've just got a couple of other things to say. We're going to be live tweeting. I know it's called X now, but I sort of feel like live Xing sounds a bit wrong. So we're going to be live tweeting during the conference. So do join the conversation online and use the hashtag UKCFC. And just to let you know, all the sessions are going to be recorded and they'll be shared and available afterwards. That will include the Q&A sessions. So if you're in the room and you don't fancy being recorded, then just either don't say your name or submit your question anonymously online. We're just filming the stage up here. The camera just to my right is what's picking up the live stream. It's just up here, so the audience here can't be seen unless you stand up and wave at our online audiences, but I wouldn't encourage you to do that. Okay, Ali is our tech guru. I'm looking at him at the back of the room. Ali, how are we doing with the Slido? Do you think we're ready to show the results yet? Okay, so where are people joining us from? Well, not surprisingly, the majority, 99 of you, or over 100 of you, are from the UK. We've got people from the rest of Europe, but also Asia, Mediterranean, the Middle East, and the Americas. So that's great. We are an international audience. Thank you to those of you especially that have got up very early, or some of you maybe it's nearly lunchtime. Thank you for joining us. Ali, should we look at the next question? So what's your relationship to CF? So I think you're able to tick more than one, but most of you are researchers, lots of healthcare professionals, 20 clinicians, and then relatives and people with CF are also represented, and I know that most of you are watching online. So really pleased that you're here, and thank you very much for being part of this. So without further ado, I'm going to hand over to David Ramsden, the CEO of the Cystic Fibrosis Trust, and he will officially welcome you to the conference. Thanks, everyone.
Morning, everyone, and I would like to add to that welcome to this year's UKCFC, and it's great that so many of you have been able to join us here. It's a lovely full room, and great that so many of you are online. These events are really important. They give us a chance to reflect on what's been achieved and be inspired by the work that's underway. But they're also, I think, critically an opportunity for people to meet virtually and in person and be part of what I think we can proudly call the CF community. I think that helps to share insights, but I think critically, hopefully also to generate some new work and some new partnerships to help to drive things forward. Since we gathered last year, it was actually May last year, a lot's happened. I was counting the Prime Ministers, but I thought that's too much scar tissue for us all to go there yet. I think it's been a deeply challenging time. However, through that time, there's also been some continued progress for many people with cystic fibrosis. I know a lot of you will be conscious that we published the registry report for 2022 on Friday, and we can see that in the numbers. The UKCF population is now over 11,000. 8,000 of that population are on highly effective modulator treatments. Median predicted survival, as calculated in the registry, is now 56. And one of my favourite statistics is that in 2022, 140 people with CF became mothers, and 33 became fathers. This is fantastic news. However, as we rightly mark this progress, we don't lose sight of the fact that CF remains a lethal disease. The highly effective modulators are not suitable for everyone, and they're a cure for no one. And the registry report also includes the stark statistic that the median age of death in 2022 was 33. These numbers validate some of the assumptions that we are making about the Trust longer-term planning and that I outlined last year. And I'm just going to run through some of them again because I think they are important for all of us as part of this conference. We expect the CF community to continue to grow. Our very outline modelling suggests we're probably talking about 12,000 people with CF by 2030. We expect the number of adults, therefore, to grow quite markedly and continue to grow as a percentage of the overall population. And as indicated by the numbers, we expect people on average to live longer and healthier lives, in some cases very much longer and very much healthier lives. We're obviously focused on the fact that the childhood experience of CF could change quite profoundly and quite rapidly. I think many of you will be conscious that we are waiting, we hope now, for a very short time for the approval of 2 to 5-year-olds for Kaftrio. It's past the most significant hurdle in Europe, and we're hoping the MHRA will follow the similar timetable. We obviously also, as many of you are aware, we're in the midst of the HDA process with NICE for the wider portfolio of Vertex medicines, which we're obviously working hard on to make sure the voice of people with CF is right at the heart of that process. We expect more people with CF to complete education, to embark on long careers of employment, and to take those life chances that we're determined to ensure that people can. But we know also that many people do not have the imminent prospect of treatment. And we also know, as we reflected later, as people age, they're going to be affected by new conditions and will require really important health, social, and welfare support. It's going to be a very complex future with those needs diverse and complex, which for the Trust is a challenge to make sure that we are making our offer and the things we do pertinent to that whole audience. And we also know it's likely to be happening in what I've written down here is a series of financial challenges, and they'll be happening at the personal, probably systemic and societal level in the coming years. We are the only UK-wide organisation that works for people with cystic fibrosis, and as many of you will be familiar, we have the second highest population of people with a CF diagnosis in the world. So we believe what you and the Trust does has a really vital role to play in driving forward positive change. And high-quality research is absolutely at the heart of that. And to deliver that, we need to get some essentials right. And I'm just going to take a few brief moments to highlight some of those essentials. I think the first, and for me the most important, is ensuring that people with CF are at the heart of everything we do and deeply involved in research at every stage of the process. The biggest risk we all face, and particularly the Trust faces, is that we're not relevant to the changing needs of people with CF. And the biggest single way we can ensure our relevance is to make sure their voice is at the heart of what we do. The James Lind Alliance Research Priority Refresh, I think, is a fantastic example of how we've all worked together to ensure that that is the case. And I know we're going to be talking a little bit more about that shortly. The second theme I want to briefly highlight is partnerships, and it was great to see that slide reflecting where everyone has come from today. Partnerships with other charities, funders, biotech, biopharma, academics, clinicians, MDTs, the whole CF community, and I suspect a lot of unusual suspects will help us make the changes we need to. CF is not a large condition, and that means that therefore those partnerships are absolutely critical to leverage the scale of change that we need to do. As a final comment, I would like to thank you all for the work you've done. You've all made a choice to work in CF and be connected to CF, and it's your support that is going to help us drive that change. I also want to thank everybody who has fundraised and supported and added their voice to the Trust, because you're also absolutely integral to what we're trying to do. I want to thank my team. They are a fantastic bunch of colleagues, and I'm very lucky to work with people who are so committed to making a real difference. And I also particularly want to shout out those people who have fundraised for us in this tough environment. Resources are hard to come by, and the partnerships we can forge and the fundraising that people go out of their way to do for the Trust and for people with CF is really important. I also know that research offers real hope, and I ask all of you who are involved in research to keep us updated on what you're doing. It's fantastic when we can tell people the progress and sometimes the challenges you're facing, to give them a real insight into what we're all trying to collectively achieve for people with CF. As I highlighted last year, the Trust has a very simple vision, which is that every person with cystic fibrosis has a long and full life. We won't stop, and I know you won't stop until we get there. So I hope you enjoy the conference. Thank you very much.
Thank you very much, David. So we're going straight into session one, and I'd like to warmly welcome Professor Jane Davies from Imperial College London to give the opening plenary, Relearning Cystic Fibrosis. Thanks, Jane.
Well, thanks, David, for that excellent kickoff. And thank you very much for the invitation today, and welcome to those of you who are joining online. It's always interesting to get a title you haven't spoken to before, and particularly when you're talking about relearning an entire topic in 25 minutes. So I'll do my best. Luckily, David has really introduced everything. We didn't convene over what we were putting in our talks. I'm glad to say that my priorities and my suggestions align with David, so that's good. Here are my relationships. I don't think that they're necessarily going to influence what I say. So in terms of thinking about why do we need to relearn, this slide was originally called What's Changed. I've changed it because it is continuing to change. It's a bit like when you're raising toddlers and you just about catch up with them and you turn around and they're already a teenager. I think this is an evolution. It's not a step change. And we've heard already from David that these are the things that I think are going to really change and continue to change the increasing adult population living with different expectations, different physical health, many of them, and different life choices. But also, really, really importantly, and I'm going to come to this as a big chunk at the end, the group who are missing out on the benefits of the new drugs that we have available for very many people. So David mentioned about the adult population growing, and I've taken a few slides from the registry actually because the pictures make a very big impact. So if you look here, the differences in the last 10 years from the 2012 registry to the 2022 in yellow, all of these patients in the yellow bars are living at these older ages. I think it's really very, very impressive that we're seeing that. But as David said, this is going to bring new challenges for us. Now, I'm a pediatrician by training, so I don't do very much clinical adult work, but I work very closely with adult colleagues, both in research and in discussing quality improvements in cystic fibrosis generally. And this is going to be a major thing, thinking about new morbidities that people with cystic fibrosis might encounter because they are growing older. And some of those might be made worse by having cystic fibrosis or by being on treatments for cystic fibrosis. And some of them we know are related to the underlying defects, such as the bowel cancer increased risk that we'll hear more about, I think, later today. But there's also a cumulative burden of the amount of drugs that we treat people with, and that builds up over time. They can start to display allergies or interactions, and we also get antimicrobial resistance that we'll hear more about later, but also end organ damage, for example, hearing loss, which is pretty common, and kidney disease despite our best efforts. And something that we don't really hear about a lot, but I'm very aware of with my own mother, who's a really, really healthy 88-year-old. But in the last 2 years, the frailty onset has become very, very apparent. And I cannot even imagine somebody of that age expecting to do the sort of exercise and the sort of physiotherapy that will keep them healthy. And we need really, therefore, to be thinking about all of this. One of the very nice things about this talk, and I'm really grateful to those at the Trust who've provided this, is that the patient voice is going to be woven through this. There was a series of meetings in which both patients with CF and also parents came together to talk about some of the issues that they're tackling. And so we're going to see a few of those people talking at this meeting. Ali's going to run the videos for me. So if we could first of all hear from somebody who's encountering aging with cystic fibrosis. Thanks, Ali.
I've got to the stage now that I am developing things that older people have, and unfortunately you just then become shunted backwards and forwards between GPs who change every time you go in and the CF team who haven't got that experience of the older person's care that I think that they need.
There are more and more of us that are reaching 50 and beyond, and it does feel a little bit that it's sort of more of a sort of suck it and see approach with the older CF patients these days, because there isn't any precedent. There's not a lot of clinical experience among the medical teams as to how they deal with us. And it's a really good point you made, Jane, about aging CF patients. Just we are going to face other conditions that the aging population experiences, day by day anyway, and there has to be probably a lot more sort of crystallised thinking in terms of how those conditions and symptoms are going to be managed alongside a whole, the medical and drugs regimens of CF. Because if you have to start taking, drugs for arthritis, are they going to conflict with CF drugs? So it'd be really nice to see some, activity in that arena, I think.
So I think I hear from my adult colleagues in the clinics frequently that CF is not the top choice for respiratory trainees in adult medicine. COPD tends to have a lot more work, a lot more money, I think, associated with it, and there is a wrong perception that CF is done from amongst some of our colleagues. So I think we really need to get to people very young, we get to them very early when they're medical students or beyond, same for scientists, and really excite them about what's going on in cystic fibrosis. We're definitely going to need this adult workforce across the whole of the multidisciplinary team as we move forward. Just one thing to highlight also that came up in the registry, though, is that you be aware there's always been a gender gap. Nearly every study that's ever looked at it has found that from about adolescence onwards, women with CF have worse outcomes than their male counterparts. And having a look at this on the latest registry data, you can see that there still is that. So the turquoise, that's the males here, living at longer ages than the females. So this is not something that has gone away. There is publications showing there's a gender gap in terms of response to CFTR modulators as well. It's something we need to continue to think about. But I was very encouraged to see this graph, which looks at the predicted survival of people into the future from the various cohorts within the registry. And you can see that those genders look as though they're coming together. So I think we've got a lot of room to be optimistic, but it's not something to be complacent about. Another room for optimism is the fantastic improvements in lung health. So this is the FEV1 across the different ages. Black 2012, yellow 2017, and blue 2020. And you can see this really big uplift at all ages across the board. And because of the link between FEV1 and survival, and also burden of treatment and symptoms, this is really very good news. And as David mentioned, this is tied in very, very strongly with the rollout of highly effective modulators. And in particular, you can see here the proportion of the population and the numbers that are now receiving Kaftrio, the triple modulator, which is suitable for all people with one copy of F508del and a number of other rare mutations as well. And of course, these drugs are the first drugs that target the underlying biochemical defect in the cells of the bodies with people with CF, as opposed to everything else we've ever had before, which treats those downstream symptoms and consequences. And because they're systemically taken by mouth, they can treat multiple organs in the body. These are the sort of pivotal phase 3 data that many of you will remember seeing, and this is the improvement in a number of outcomes in people who only have a single copy of 508 and their other gene mutation is non-responsive to these drugs. So this is the impact that we can make. These, of course, are clinical trial data. They're highly selected, but there's a large array of real-world evidence coming out now, and I've been involved in one of these studies led by Paul McNally out of Dublin, looking at real-world evidence of triple therapy in patients with cystic fibrosis. In addition to all of those benefits that we're seeing in the trials, we've shown significant improvements in the highly sensitive lung function test, lung clearance index, and substantial improvements that you can see with your bare eye in their CT scans. Really, really very impressive. But of course, it's not all about the lungs. And one of the things that is captured in the real-world studies, which wasn't so much focused on, I think, in clinical trials, is things like abdominal symptoms. And we'll hear about abdominal disease later on in this afternoon and the burden that that can impose upon people. Here's some very nice data from the Recover study led by Joachim Mainz out of Germany, where you can see in this spider plot, the smaller the area, the less the burden of symptoms in that particular domain. So in all of these domains, apart from one, we saw a significant shrinkage, so an improvement in people when they were receiving triple therapy. And really just to acknowledge the funding that was partnered by the CF Trust with CF Ireland and the Foundation in supporting this. It's still ongoing, and we've just had a grant to look at younger and younger patients as well in this regard in a real-world way. So David mentioned his favourite statistic. It's a really, really exciting statistic. So compared with 2019, there are 3 times more women with CF who became mothers in the last registry cohort. So this, you can clearly see the improved health and well-being, and some of it directly related to their fertility, but some of it related to optimism about the future, is really changing the way adults with cystic fibrosis are making very, very important life decisions. One of the things that I think we need to focus a little bit on, though, of course, is that we know that these drugs cross the placenta, and we know very well that, in fact, in animal models of cystic fibrosis and in rare case reports of children who have cystic fibrosis, there can be improvements in disease related to that crossing the placenta. So I think we do need to focus on this cohort of people coming through. These drugs are not licensed during pregnancy, but they're being widely used because of the detrimental health impacts of stopping them. But I think we do need to understand more about that as we move forward. So this is all the good stuff. I think we're in a really, really good place, but I don't think that we're finished, and David has really highlighted this, and these are the reasons I don't think we are. The burden of treatment does remain for many people. People who only get onto these drugs in adulthood and who already have fixed, established disease are going to continue to need better treatments, and we need to make sure that they're not as burdensome as they are at the moment. Some people get side effects or intolerances, which mean that they can't continue to take these drugs, and dose adjustments can be very challenging. We really, I think, many of us would agree we need to get some sort of drug monitoring for these patients, and we need to be able to actually understand how we can titrate to individuals rather than having a single fixed dose for anyone, no matter what size they are. Another thing that comes up quite a lot, and you're going to hear patients talk about this as we move forward in the talk, is recognizing when things aren't right. So both the person themselves, people are experiencing that an exacerbation could be really a bit different, and how do they know when they're not well or they've got a new infection? But also there's some sense that will come out in one of these talking pieces that we as teams need to be better at recognizing when things aren't right as well. And then one of the areas of my research is that we have a lot of infection challenges, I think, moving forward. These drugs do not get rid of chronic infection. In very, very few people are we actually seeing that, and in the majority it is sustained, and so is the inflammation that arises as a result of that. And then, of course, this very big group who is missing out on any opportunity of treating the basic defect. So in terms of the treatment burden, most people say that the most burdensome treatments are those that are delivered by nebulizer into the lungs. They take a lot of time. Looking after the equipment takes a lot of time. And if we look at the proportions of people who are receiving these drugs, they're still very high. So no inhaled therapy was less than 20% of people on the registry just now. And that's despite the fact that some people are taking themselves off these drugs because they're feeling better. So it's really, really important that we try and find out what can safely be stopped without harming people's outcomes. So many of you will be involved in the CF STORM study. This is led by Kevin Southern and Gwyneth Davies, both of whom I think are probably here today. And this is a really, really important study which we need to put all our energy into recruiting to see whether people can safely, without detriment to their lung health, come off some of these very burdensome treatments. We do have some quite positive data from a similar study out of the US, but it was much shorter, and people recruiting to that were generally pretty healthy. So I don't think we yet have the answer. So anybody who's working on that, please encourage your teams to really continue to put a lot of focus into recruiting. We really need to get numbers in that. And then something I get asked a lot, and which I think is going to come up in the next talk you'll hear, is maybe actually in some of these new children, if you start one of these drugs at the age of 2, for example, maybe we'll never actually need to start some of these drugs. But where's the rule book? Where's the evidence? We haven't got any of that. And certainly as these drugs come further and further down in age, as they probably will, because it's happened with ivacaftor, we're really not going to know what to do. We need to think very, very carefully about how we manage this, how we don't detriment their long-term health, but we also manage to limit the burden of treatment. So there's a mother with a child with CF who's going to talk to us a little bit now about her experience of living through this era. Thanks, Ali.
George is still very young, so I obviously live with the fear of what lies ahead with IVs and, you know, developing Pseudomonas and that. So I'm at the fear stage. We haven't experienced that. So, but I suppose the only thing is the likes of everyone that started Calf Trio and that, and I know there'll have to be still a lot of research, but to see, you know, how much physio is still going to be needed, just to see the difference in that.
So I think many of you will also have encountered this in the clinic. We used to have a not very good idea of what an exacerbation was, and now our idea of that is even worse, I think. I think exacerbations can quite often look quite different than we conventionally recognize them, and things can get missed. And this is something that patients are describing, and there's 2 videos that are coming up now that describe different aspects of that, and I think are certainly worth us listening to. I think some work needs to go into this area of redefining an exacerbation in people who are receiving modulators.
I mean, I've noticed that my lung function can be the same. And it wasn't until I was doing one of these sessions that somebody mentioned that they'd noticed that when they weren't well now, the first way of finding that out was that their heart rate increased a lot. So it is quite hard when you, I mean, obviously it's much better to be on them, but it is quite difficult to find what the problem, if you have got a problem or you just having a bad day. And it's like, how long do I leave this before I do something about it?
And if we could just go on to the next video as well, Ali.
I think CF teams and CF people who are researching CF and everything kind of have a tendency to think about like groups and trends and not individuals. And it's been really frustrating. I think especially my experience before going into hospital, I knew something was wrong, but because I'm on Calf Trio, you know, people are well on Calf Trio. It's all fine, and nothing could possibly be wrong because, you know, you don't appear sick, you're not coughing. I don't feel like the individual response to CF itself and the individual response to Calf Trio is being emphasized and recognized enough.
So it sounds like there's a bit of work for us within the teams to do there. One of the things that Jane talked about was the heart rate, and you know, there's an interesting move towards providing more care remotely and also using devices to try and do this. Andreas has done a lot of work in this and is going to talk later about his research, so this may come up, but it's something that there's an awful lot of focus on. We need to make sure that we're delivering this in partnership with patients in a way that they find acceptable and that we don't swap the burden of treatment for the burden of monitoring. And then I've also mentioned, I think lung infections are going to be a major challenge. they themselves may be less obvious to people with CF. We've heard this, you don't necessarily cough, you don't necessarily get symptoms when you've got a new infection. We're dealing now largely with an adult population who can't produce sputum, the gold standard for culture, and people are moving into more novel ways of trying to explore this with infection biomarkers, with breath monitoring, for example. And we're also very interested in how mixed infections can interact with each other. So, for example, we've got some work showing that one type of pathogen can actually mask the presence of another. This is Aspergillus fumigatus, work that Dom Hughes did in our SRC for his PhD. And we know that Pseudomonas, or certain isolates of them, can produce toxins that can get out of the Pseudomonas and impact the growth of other pathogens around them, to the extent that you can see here this zone of clearance around the Pseudomonas on a fungal plate. And we've shown that within patients, this seems to be happening, so we're missing Aspergillus growth in patients who are co-infected with Pseudomonas. We also know that when things are in a polymicrobial environment, their responses to treatment might be worse. And we're also, there's increasing attention in a number of groups worldwide to look at how polymicrobial infections actually interact with the host. And thinking, well, we probably would have thought more infection is bad, but actually maybe that might not be so bad. And Michaela, one of my PhD students, is doing a flash poster later today where she'll outline that with Pseudomonas and staph and some very intriguing data she's got. So the rest of the talk, we're going to really think about the people who are missing out on these modulators, and they're missing out on a lot of this progress. And there's a rapidly increasing attention on the genetic therapies, which I think include gene therapy, mRNA-based therapies, and rather more in the future, perhaps gene editing. So there's a number of different approaches which can be taken. And I'm really pleased that I'm part of a working group formed by the TDN at the CF Foundation to try and actually map out proactively some of the challenges of this. You can see all of the working groups down there, and this is led by Chris Goss and Manu Jain. And I think it's really, really timely, and there's work going on at the CF Trust and also within the ECFS to try and get us as a community ready for this hitting, because I think we have a number of challenges. This is a small population. It's an important but small population, somewhere between probably 8 and 12% of the CF population, depending when you are. There are a number of different trials and different approaches coming at once at us. Now, some of those will be short-acting things like messenger RNA, which will need to be given frequently and may be more of a burden of treatment. Others are long-acting and may be able to be dosed less frequently, but there's a huge amount of unknowns about all of them, both in terms of safety and efficacy. One of those unknowns is also about whether people who've been in one gene therapy trial will be allowed to enter another one after a period of washout, for example. And how do we support people to choose this? And I think this is really, really key, and I'm pleased that the Trust is doing some work around this, and so is ECFS. But we'll hear now from one mother with a son with cystic fibrosis about this particular issue.
So it suddenly dawned on me after 18 years of not having only having symptom treating options and nothing for the underlying cause of his disease. We've suddenly got 2 trials coming up very soon. I don't know if there's a word for the opposite of a hypochondriac. He always just talks about how well he is, and he's not. He just says, I'm fine. At his very worst, he'll go, not the best. But he will never really admit to actually being really quite poorly. A future with something, the mRNA, as I understand it, Belinda, I don't want to say too much in front of Belinda, who's an expert, but would provide the scaffolding for him to make that protein properly, as I understand it. And so it would be a daily nebulized drug. Whereas the gene therapy trials, which hopefully will start in the new year, spring time, whereas the mRNA ones we're talking about October, so really quite soon. The gene therapy trials, the outcome could be 1 nebulizer every 6 months.
Oh my God.
1 nebulizer every 6 months. That's amazing. That is, so I know for an 18-year-old boy what he would choose.
So just wrapping up now then, something that the working group of the CF Foundation has done, which I think is really important, is it has looked at the community voice in terms of knowledge about these new treatments. And if we look at the bottom line, the CFTR modulators, most people know quite a lot about them. There is a gap between all respondents and those who are non-white, and there seems to be a learning need there. But you can see that when we come to the genetic therapies, the overall level of learning and knowledge is much lower, and that gap in some cases is much bigger. So this is a very big area that we need to work on. We know that most of the people who are missing out because of their genes actually come from ethnic minorities. And so they may already have limitations to access of healthcare, or they may have perceived burdens. And this is something I think we need to work on quite hard, and I'm pleased that across the board people are doing it. But I also think it would be remiss of me not to think a bit more globally. And I think we're highlighting challenges here, but actually in this country we are incredibly privileged on a global scale compared to people living with diseases in under-resourced countries. This is just a map of world hunger, but you can see the very, very stark differences globally, and we know that populations of people with cystic fibrosis in these very under-resourced countries, firstly, they have limited access to diagnosis, they have limited access to conventional treatments, and certainly when we're talking about these very effective novel treatments, their access is very, very poor in the majority of regions, and this is something that in the ECFS we're really trying to think about how we more proactively discuss and help this rather than just going, oh dear, yes, it's really bad. So David mentioned the top 10 priorities. I think it's always worth us coming back to these. A lot of these have been covered in what I've talked about. I won't go through them again, but for those of you who are perhaps a bit newer to CF, it's always worth referring back to these when you're thinking about what your research should be. This has been heavily influenced by people with cystic fibrosis, and really we need to keep an eye on this as we move forward. Just one other message that came across to me from the videos was that people want to be treated like individuals. They don't want to be grouped together in the way that we show group data and that sort of thing. And I think that's something for us to really bear in mind, an individualized approach to diagnosis, picking up complications and treatments is something we really need to focus on. So I would really like to thank those individuals who contributed to the videos. I haven't met any of them, but the videos were really great. Thank you very much. And also thank you to Lorna and Belinda who convened that, and the whole of the Cystic Fibrosis Trust. Thank you for your attention this morning.
Thank you so much, Jane. A really compelling start to the day, and I think we know there's been huge progress for some, less progress for others, and both the evidence and people with lived experience are telling us what still needs to be done. So I think we're all excited to hear what's in progress at the conference today. We've done a slight agenda swap round. So we've swapped Professor Andres Floto with Dr. Lucy Allen. So Lucy's up next, and she's going to tell us about the CF Trust research strategy. Thanks, Lucy.
Thanks, Catherine, and thanks, Jane, for the lovely setup to this presentation. So thank you all for joining us today. Really appreciate you taking on that risk with the travel, etc., and to you joining us online. I hope you find the day is engaging online as well. So I want to take this opportunity to talk you through the Trust's research strategy and try and illustrate how we're looking to address some of those research priorities for cystic fibrosis. So as David has already said, and I'm sure you are all aware, the vision for the Cystic Fibrosis Trust is that we're uniting for a life unlimited, which means that every person in the UK affected by cystic fibrosis can live a long and full life. And we recognise that people with cystic fibrosis will engage with the Trust in different ways, and therefore we have a number of interconnected goals that we're driving to support the community. So that's ensuring people are physically well, mentally well and supported, and are fulfilled, have a part of a connected community. We also recognise that each of those goals is underpinned by research, and our vision for research across the Trust is that we are supporting and enabling the delivery of a broad and dynamic portfolio of world-class innovative research underpinned by high-quality healthcare data that ensures that every person in the UK with cystic fibrosis can live a long life. And there are a number of goals that we are working towards that will help us deliver that vision and mission. And I'll talk you through those goals and provide some examples of how we're using those goals to help us address the research priorities for cystic fibrosis. And as Jane has already beautifully introduced, last year we went through a process of refreshing our research priorities for cystic fibrosis, because we want to make sure that everything that we do across the Trust is underpinned and driven by the voice of the cystic fibrosis community. And this priority refresh project was an internationally collaborative project which was led by us at the Trust, but also by colleagues at the University of Nottingham, working in partnership with the James Lind Alliance. And these have been incredibly important and will help us shape and drive the research strategy going forwards. It goes without saying, as a research charity, we want to make sure that we are supporting world-class research, and we're incredibly lucky in the UK that we have a great portfolio of research across that research pipeline, all the way from basic science through to the support of late-stage clinical trials, and also follow-up studies looking at safety and efficacy of drugs and therapeutics in the real world. So we have a number of flagship programs that we support across the Trust that I'll talk through in a little bit more detail. So we have our Strategic Research Centres, our Venture and Innovation Awards. We also support the Innovation Hub at Cambridge, which Andres will talk about later, and we have the Antimicrobial Resistance Syndicate for Cystic Fibrosis, which is a partnership between us, the Medicines Discovery Catapult, and LifeArc, and Paula and colleagues from the Medicines Discovery Catapult will be talking through that in more detail later also. So our strategic research centres are multidisciplinary awards that are up to £750,000 funding over 3 to 4 years, and they bring together groups of researchers working in CF but also from outside CF. And since we've started funding the strategic research centres in 2013, we've supported 25 SRCs, which has allowed us to support and fund over 150 scientists and specialists from over 50 countries around the world. And obviously you'll hear a lot from our SRCs today because it's our opportunity to showcase the research that's going on within the SRCs and update you on their progress. I just wanted to highlight the gene editing SRC, which Patrick Harrison will be talking to you later, as this is an example of one of our co-funded SRCs, so it's supported by the Cystic Fibrosis Foundation. We then have our Venture Innovation Awards, and these are leverage funding awards that allow us to fund in partnership with other organisations, and that's really important in making sure that the money we have available through donations and fundraising to support research goes as far as it can and makes as much impact as it can. And since we started funding the Venture Innovation Awards, we've been able to support over 100 VIAs. And from an investment of £5.1 million from the Trust, we've been able to leverage over £27 million from other external organisations. So these are a really powerful mechanism for us to be able to fund more research. And you'll be hearing later from Dr. James Rahill, who's presenting the VIA he's leading, which we funded in partnership with UK Research and Innovation, Queen's University Belfast, and a commercial organisation. You've heard David mention that it's really important that we work in partnership, and we've established some really, really significant partnerships, which have allowed us to leverage additional funding and bring additional expertise into cystic fibrosis. And that's a really important way of us working together with other organisations that share our drive and priorities to make best impacts for the CF community. One of the examples you'll hear about later is our partnership with LifeArc and the Medicines Discovery Catapult, but working with LifeArc has really allowed us to unlock some significant additional funding into the areas of understanding infection, treatment, diagnostics, and antimicrobial resistance. And earlier this year, we were able to launch a new funding programme of £15 million, looking to establish a series or network of innovation hubs. And this is based on our original innovation hub model, which is currently running at the University of Cambridge, led by Andres Floto, which is a strategic partnership between us and the University of Cambridge. So it's really exciting that we're able to build on that original model and really demonstrate the impact and unlock additional funding with the great support from LifeArc. We're engaging with a number of other research partners across the research priorities, such as Emily's Entourage, and this is an American-based charity that's looking at funding research for those who aren't eligible to take modulators, and we've been able to fund a novel gene therapy platform with Emily's Entourage. And then we also have partnerships with Cystic Fibrosis Canada and Action on Hearing Loss, or RNID, looking at funding research that really addresses those research priorities. We've got a significant partnership and relationship with the Cystic Fibrosis Foundation, and we're incredibly grateful for them supporting the funding of the UKCF Clinical Trials Accelerator platform and also co-funding several of our SRCs, as I've already mentioned. The refresh research priorities have given us a really exciting opportunity to think about how we can bring new expertise into the field of cystic fibrosis and build new partnerships to address some of these really tricky challenges. And as Jane's already mentioned, the challenging of managing an ageing population is significant at the moment. And we're bringing together a workshop later on this year working with other external funding bodies such as the British Heart Foundation, Medical Research Charity Council, and also Cystic Fibrosis Foundation to bring new expertise into the room with cystic fibrosis researchers and really unpick what those important research questions are to help us drive more research into these areas. And similarly, we'll be doing the same with Diabetes UK, looking at how we can prevent cystic fibrosis diabetes. Both Jane and David have spoken about the impact and the importance of the UK Cystic Fibrosis Registry. It's a goldmine of data and information, and we need to make sure that we're using that to drive and stimulate research. So there's a number of different ways that we can use the registry data to engage with pharma, so looking at doing trial feasibility so we can identify where there are patients in the UK that can participate in potential new opportunities, new studies, so the genetic therapy studies, for example. And also there's important pharmacovigilance studies running through the registry, looking at whether these new drugs are safe and effective in the real world. Jane has already mentioned that we can support the delivery of clinical trials such as CF Storm, looking at whether there's opportunities to reduce the treatment burden for those taking modulator therapies. And there's a QR code there for anybody who'd like to see the recently published 2022 registry annual report, and a big thank you to all of the team that are involved in producing that report, because it's been a mammoth effort, but also a big thank you to the CF community that are contributing their data to the registry as well. So we obviously have great infrastructure across the UK, and we have the ability to fund really exciting research, but we need to make sure that we are continuing to build that research capacity and capability to make sure the UK continues to be recognised as the place to come and do cystic fibrosis research, and that we are retaining and attracting new talent as well. So we have a number of different ways through which we fund and support capacity and capability building. We obviously have the Cystic Fibrosis Trials Accelerator platform, also known as CTAP, and this was established in 2017, funded by the Cystic Fibrosis Foundation, and is a network of 27 research active CF centres who have funded trial coordinators and research nurses. And this network has been fantastically active. We've delivered or opened over 50 trials since it was established, and 15 of those studies were opened in the last 12 months. And the types of studies that the platform supports can be pharmaceutical studies, so looking at the next generation of modulator therapies. They can be academic-led studies, such as the terrific study, which I think Darius Armstrong-Jones will be talking about later, is part of our Aspergillus Strategic Research Centre. And as Jane has mentioned, we're now getting ready to support the new early phase genetic therapy studies, which are looking to open in the next 6 to 12 months. There is also a link on the right-hand side of the screen there to the Cystic Fibrosis Trials Tracker, which lists all the currently open studies and also closed studies that are run through the platform previously, and where possible we've started to provide information about the results of those studies so we can feedback on the impact of those trials to the people that took part in them. We also support early career researchers through a number of different mechanisms. So we have co-funded fellowships with external organisations like the Medical Research Councils, National Institute of Health Research and the European Cystic Fibrosis Society, where we co-fund a doctoral fellowship. We also support a small number of summer studentships each year, and I'm really pleased we've got a number of those students here today. So please do go and talk to them, engage with them, go and see their posters. And we have several of our early career researchers that are supported through our SRCs and our VIAs presenting posters today, and I'm really looking forward to that flash poster session as well. So we've got great infrastructure, we're funding great people, and we're doing great research, but we need to be able to talk about it. We need to talk to the CF community so they know what's happening, and they can see the impact of the research that we're funding. And we also need to talk to our supporters so that we can encourage them to continue to give, so they recognise where their money's going and why there is a need for it. And there's different ways we can talk about our research. So we have Research Wednesday on social media, so you'll often see posts about new research or new clinical trials that are running. We're also running a series of researcher profiles, so we get to know the researchers that we're funding and their interests and their reasons for doing CF research. We obviously have our conferences, so this one and the Clinical Trials Conference early next year. And then we have annual impact reports that really put numbers to the research that we're funding, talking about the number of early career researchers that we funded, the number of papers that have been published, for example. We can support press releases when we know about new research that's about to be published, and then we have a community-facing magazine, CF Life, where we try to make sure we have research articles in that wherever we can. And this is a big plug from Belinda, who's sitting down at the front here and whose picture's on the screen. Please do come and talk to us if you know you're getting research that's about to be published or you're speaking at a conference. Please do come and talk to her. And if you want to volunteer to be a researcher, to have a profile piece written, Belinda would absolutely love to speak to you. So please do come and harass Belinda later on. And you can also email her. For those of you who are online, you can email her as well. So just about to wrap up, but a couple of save the dates from me. So we have a community-facing CF Live event on the 17th of October. So that'll be a wrap-up of the conference today, led by some of our early career researchers. So thank you for those of you that volunteered to help us with that. It's a really important way of translating some of the science here into something that's a bit more accessible for the lay members of the audience. We also have our CF and Ageing workshop on the 4th of December. So if you would like to attend that and are interested in ageing research, please do get in contact. We have our clinical trials conference in Leeds, which is led by Daniel Peckham, who's sat very quietly over there, trying not to make eye contact. And then we have a MDT conference again in Leeds in March. And we will be back with UKCFC in the autumn of next year. So if you'd like any more information about that, please do talk to any of the research team or any of the rest of the trust staff, or you can email the conference inbox. So I just want to say thank you again for being here, for showcasing your research. If you're talking, really looking forward to the rest of the day, and please do come and find me and say hello. Thank you.
Thanks very much, Lucy. For those of you watching on the live stream, we know we've been having, some of you have been experiencing some technical glitches. Just to reassure you, we're on the case and sorting that out. Everything has recorded fine though, so if you did miss anything, you can always go back and listen to it later. So next up, we've got a series of updates on 3 research partnerships that the CF Trust is involved with. The first partnership update is entitled AMR Syndicate, Connecting the Community for Impact. So please welcome to the stage Dr. Paula Sommer from the CF Trust, Connie Takawira from the Medicines Discovery Catapult, and Dr. Ed McIver from LifeArc. Thank you.
So the CF-AMR Syndicate, or Antimicrobial Resistance Syndicate, is a partnership between LifeArc, Medicines Discovery Catapult, and the Trust. And together with Connie from MDC, and Ed from LifeArc, we're going to give you an update on the Syndicate's activities this past year. So antimicrobial resistance, a silent pandemic, is a problem for all of us, but particularly so for people with cystic fibrosis, who are susceptible to developing lung infections. And once these adapt to the CF lung, they become difficult to treat. And so antimicrobial resistance, or when the antibiotics simply no longer work, is frequently seen and is a cause of mortality. So we're very fortunate to be in the era of CFTR modulators, for those who can benefit. But there are still many who can't benefit. And as Jane has already said, the longer-term effects of the modulators on infection are not that well understood. And it's even more complicated by the fact that when people are on CFTR modulators, they're less able to produce sputum on demand, which is good, but complicates the diagnosing of infections. So antibiotics remain a key and necessary therapeutic in cystic fibrosis. But there have been no new antibiotics for decades now. And so there's an urgent unmet need for the development of new antimicrobials and diagnostics for CF infections. And this is far more eloquently said by Aaron, who in a video clip that MDC produced for CF Week said, "Antibiotics have literally helped me my whole life. Now, from going from having 6 or 7 options, I think I've only got 3. So the mission of the Syndicate is to accelerate the translation and adoption of new antimicrobials and diagnostics for CF infections. And the Syndicate really is uniquely structured in that to provide guidance on the medicines discovery and diagnostic discovery roadmap for innovators that is informed by the needs and priorities of people with cystic fibrosis. Connie will tell you a little bit about how the Syndicate is creating an ecosystem of specialist enabling research resources for these innovators. And the CFAMR network is there to facilitate the formation of R&D collaborations to really drive forward discoveries. And then Ed will tell you a little bit about how the Syndicate is promoting access to specialist support and funding to really advance antimicrobial programs. So the unique structure of the Syndicate lies in the managing partners, together with leading experts from academia and industry, clinical teams, funders, investors, commercialization and translation experts, all anchored by the involvement of people with cystic fibrosis, whose involvement activities really thread throughout all of our activities, all working together to accelerate the translation of new antimicrobials and diagnostics to the clinic.
So one of the things that we did in the beginning was we brought together the whole community to try and understand what some of the challenges were, so what the barriers were that people faced in research when it came to getting their compound from the bench to the clinic. And of the challenges we identified, we sort of thought quite pragmatically, where could we actually focus our efforts on and deliver the most impact? So two key challenges that we decided to focus on. The first was around the difficulty that researchers faced in accessing the samples that they need. And then the second challenge that we also identified and chose to focus our efforts on was around the fact that there's no agreed preclinical testing pathway. So from this, we've developed a suite of enabling tools and resources, which really is a portfolio of collaborative R&D projects that really try and address these two key challenges that we decided to focus our efforts on. The first of these projects is the UKCF Infection Biorepository, which has been in existence since 2019. And the biorepository really is there to make it easier for researchers, whether they're in academia or in industry, to be able to get the samples that they need to test their novel compounds on, or be able to work on their diagnostic technologies. So the biorepository, it's a virtual biorepository. It links up 9 centres around the country. There is a central coordinating point at Medicines Discovery Catapult. Across all of these 9 centres, there are well-characterised CF-relevant pathogens, strains, as well as sputum samples that are available. So researchers can approach the coordinating centre and make some inquiries, and we can introduce them to the relevant centre. All 9 centres are actually linked up to a specialist CF centre, and all of these labs also come with relevant expertise as well. Just very recently, we actually signed up all the centres to a single MTA. So this, we think, will actually make the process a lot quicker for researchers. So there were significant delays in the past, and this is just going to speed things up a lot more for them. The second of our projects is something called Target Product Profiles. And for those of you who don't know, Target Product Profiles are basically a guidance document that drug developers or innovators in diagnostics would use to basically understand the key characteristics that their novel compound would need to have in order to meet the needs and priorities of people with CF. So the first of these TPP guidance documents is around novel therapeutic compounds for novel antimicrobial therapeutic compounds, I should say. And this document is readily available, so you can request it via our website. But the TPP guidance document, the unique thing with this is it's developed around the needs and priorities of people with CF. In order to understand what those were, we first of all engaged with people with CF. So we held focus groups with people with CF, and then we held focus groups with clinical teams to also understand what needs, what challenges they faced. So this was an iterative process. So following on from those initial focus groups, we held one-to-ones with key opinion leaders and industry experts for their insights. And this all culminated in a Delphi survey and a virtual symposium. So just tying in with what Jane said earlier, treatment burden is a real issue among people with CF. So this is one of the key considerations that's salient throughout this document. The next is a TPP guidance document on diagnostics, which we actually released yesterday. Much sort of in line with what Jane was saying earlier and what Lucy has mentioned, or several people already, there has been some key challenges around diagnosing infections in people with CF, so being able to detect and diagnose when someone's experiencing an exacerbation. For some people with CF themselves, their symptom profile has changed, so they don't always know if they're experiencing an exacerbation. So these are some of the key things that are threaded throughout this document. Obviously, you've all already seen the JLA top 10 priorities already in the previous slides. There's been some issues around how best to monitor for infection in the absence of sputum. So these are key themes that we've pulled into the document. And in a similar process to what we did with the therapeutics TPP, for the diagnostic TPP, we first held focus groups with people with CF and then with clinical teams. And we also undertook a scoping exercise to try and identify what diagnostics are currently available and what diagnostics are also in development. So our draft TPP document is now out in the community. We really need your input. We could really use your insights in what we've put in there. It will really help us identify anything that's missing or any information that we need to revise or strengthen. We are disseminating a survey out alongside with the document, and we're inviting people to read the document and then input their thoughts, comments via the survey as well. So we're trying to distribute this through the various networks. So we're identifying the various clinical networks, the various industry networks that exist out there. So we need your help. So please do fill it out when you come across it. I'll pass you on to Ed, who will tell you about the Collaborative Discovery Programme.
Okay, hello. I'm going to talk about the CF AMR Syndicate Collaborative Discovery Programme, which we launched earlier this year. And this is an exciting initiative aimed at funding early preclinical stage programs. And this is really sort of looking for the antibiotics of the future. So, to address, to increase the number of antibiotics available to the patients, such as Aaron. So this is a 3 million funding call over a 2-year time frame. And the intent is to select between 3 and 5 projects for collaborative funding and support by the end of this year. And the hope is that this will provide the collaborators with the funds to be able to do a key phase of research, to take it to the next sort of value inflection point, and should put them make them well placed to attract follow-on funding and further development. So it's really important to say that this portfolio will be actively managed. So we won't just be handing over the money and saying, good luck, tell us how you've got on in 2 years' time. The collaborators will receive ongoing support and expert drug discovery advice from multidisciplinary experts from across the syndicate, as well as project management input throughout the call. And we believe that this approach will increase the likelihood of a successful outcome of these projects. So in terms of the scope of the call, well, this is very much an earlier phase drug discovery project, and it will be starting from sort of hit validation phase all the way through to early sort of preclinical development and candidate selection. And we think that this is a phase of drug discovery which is perhaps a little bit underserved by many other push funding schemes, such as CARBEX, which tend to fund at slightly later stages. So we believe that this will actually complement existing push funding schemes, and the hope is that perhaps those will be able to take on projects that graduate projects from this call. And in terms of a little bit more about the scope, so it's very much been informed around the patient-focused TPPs, which Connie has already mentioned today. So very much focused on trying to develop new treatments which reduce the burden of care, sort of existing therapies, because that's, as patients are getting older, as we've heard about today from Jane as well, it's really important to, to address this. But also novelty is very important as well. And we feel that, we want to develop therapeutics. The next generation of antibiotics should be targeting novel biological mechanisms which work in different ways to existing antibiotics. And we believe that this will, this approach will, potentially combat resistance, which, resistance pathways seen with, current antibiotics which are already on the market. And this call was open to academics and SMEs globally. So very quickly, I'll go through the call process and timeline. So we launched the call at the end of March this year with an online webinar. And we asked the applicants to produce a short, non-confidential expression of interest. And we did provide support leading up to the EOI submission, and the potential applicants had the opportunity to book a call with the syndicate to discuss their project. And we got a really good response from this, and we got 36 applications, high quality applications from a broad range of academics and SMEs globally, and really, really diverse range of novel and exciting projects as well. So it was really good to see that. So we then triaged these down to a list of 10 potential projects which we progressed into the full application phase. And so for those projects, we organised an online workshop for the successful stage 1 applicants, and we had a range of speakers from across the syndicate, sort of informing them of the advice and expertise and potential offerings that the applicants will be able to tap into. We also had representatives from the pharma sector who had experience in the in antimicrobial drug discovery. And we also continue to support the applicants all the way through to the final submission deadline. So we had a series of one-to-one meetings so we could engage with the applicants and take a look, for example, at their draft application and give feedback on that. And then the submission deadline was at the end of July, and we received 9 completed applications in the end. And now we're in the final stages of project selection at the moment, and this involved sort of detailed scientific due diligence from the from LifeArc's Opportunity Assessment Group. We sent the applicants out for external key opinion leader review. And we also engaged with the CF community. And massive thanks to Lorna Allen and Maddie Still from the CF Trust involvement team for organising an excellent online workshop where applicants had the opportunity, where the CF community had the opportunity to input into the applications and and rank the proposals. And all of that was fed into the selection process. So we're hoping that by the end of this month we'll be able to notify the successful applicants of which projects we intend to take forward, and then we'll be working up to project initiation hopefully by the end of this year. And I'll hand back to Connie.
So the last of the projects in our portfolio is a syndicate-affiliated project called Pipe CF. And this is an SRC that is co-funded by the CF Trust and the CF Foundation, and it's led by Prof. Joe Fothergill. And this SRC really is focused on developing an evidence-based preclinical framework. There are, I think, some posters probably outside, so some of the researchers are showcasing their work outside, so please do go and take a look. And finally, we have been trying to build and grow our network. So we are trying to get the whole CF community together, clinicians, academics, people in industry, We will be running workshops really to try and facilitate knowledge exchange and spark collaborations. So we are just encouraging people to join our network and stay up to date with relevant news and any workshop and events that we've got running, because we'd love to have you. And that's it.
Paula, Connie and Ed. Our next partnership update is more of an interview format, so I'd like to invite Dr. Catherine Kettleborough from LifeArc and Lorna Allen from the CF Trust. They're going to sit here and have a conversation about partnerships with LifeArc, the value of expert lived experience. Thank you.
Strange, isn't it? Hopefully our microphone's working. Yeah. So I'd like to introduce myself. I'm Lorna Allen. I'm the Involvement Manager at the Cystic Fibrosis Trust. So really responsible for leading the involvement work stream, ensuring that the voice of the community, people living with CF and their families, influence the work of the Trust, but also the external organisations that we collaborate with. And I run that work stream along with Maddie and Claire, who are also here today. The purpose of this session is to showcase our partnership with LifeArc, but also to demonstrate how influential that community voice has been. So I'm really pleased to introduce Katie.
Thank you very much. It's nice to be here.
So we've got some questions ready. So wanted to ask you really, what prompted you in the first place to contact the Trust for the insights of the community? And did you have any preconceptions about what might be achieved?
Okay, so thanks, Lorna. So it's probably helpful if I give you a little bit of a background and context to LifeArc and who we are and what we do. So we are a UK registered charity, and we're a not-for-profit company as well, very much working in that translational space. So we're talking about where ideas are coming out of academia and they maybe need a little bit more help and nurturing to get them to a point that a company or a partner can take them on and move them into patients. And we've been operating this space for about 30 years now, and we do it in a variety of ways. So we offer advice, we offer collaboration and funding, and we've also got some lab-based facilities where we work with people on specific projects. And as part of that, we've got a long heritage in antibody engineering and worked with a number of companies taking on their antibodies, humanizing their antibodies. 4 of those are actually are actually being used to treat people. One of them is Keytruda. So if people know about Keytruda, it's one of the first immuno-oncology drugs. It's now used to treat 16 different cancers. And as a result of our involvement in that, we actually have a royalty. We monetarised that royalty in 2019 to the tune of $1.3 billion, which means that as an organisation, our perspective really changes, and you're really challenged in how can you make a difference. And we went through a series of looking at what we could do and how we could work with people, continuing to be in that translational space. But it means now we have the freedom to think about dealing with what are those real issues that need to be addressed. And so where we're focusing is on areas of the underserved, where there are patient communities that we feel that we can impact in and make a difference if we work with partners. And what we want to do is bring together all of the offerings that LifeArc has. So yes, it's the funding, but it's also the advice, and it's the platforms and things that we have in our lab facilities as well, so which is why we're very involved with the Syndicate too. So we're calling these translational challenges. We're looking to invest up to £1 million in those through collaborations, etc. And I lead the chronic respiratory infection translational challenge. Now, and that deals, we're really very much focusing on people that are living with bronchiectasis and CF and have those chronic respiratory conditions. So that's the kind of long-winded background. But in answer then to your question, so we then approached you, and I think it was, June 21? So it was kind of in the middle of the whole COVID period when we'd identified this as an area that we would like to work with, but we wanted to understand what the real needs were. And so we had a strategic positioning workshop online. It was great to see Jane, because Jane joined that, and Charlotte was there, and Ollie was there as well as yourself. And then there were a number of people in this room that I can see that were also involved in that. And that was great, because what it meant was we had that real lived experience of understanding what it was like to live with CF, and also the hopes that people had for new interventions. And I think that really helped us shape what our priorities were and where we thought we could help with others. So it was around that earlier detection, right diagnosis, and better treatments. And I think that's where we kind of got to, and it was been really great to have that and then to use that as a kind of launch pad. I think the other thing that was really influential was it was important for us to inform the whole of our organisation. And so, again, we got involved with you, Lorna, and had a company-wide online seminar where people could ask questions. And we had people like Shad and Lizzie and Luke and Kieran, all who contributed to that. And that was great.
Brilliant. Yeah, we've had some really good opportunities. And it's nice that it's been a series of opportunities as well. So what do you feel that you learned from the CF community representatives, and how did that inform the LifeArc? So in other words, what was the outcome of the engagement?
Yeah, and I mean, that's very much ongoing. You know, I think it helped us formulate that initial strategy, but then as we've moved forward into some of the bigger initiatives, so for example, we launched a repurposing call back in November of last year, but that had been very much shaped by an online workshop that we had with the MRC, looking at repurposing for bronchiectasis and for CF. And again, we had someone, Daniela, who lives with bronchiectasis, and Angela, who lives with CF, talking at that and grounding that workshop. And we've then broke out into sort of little workshop groups, online groups, and where we could, people that were living with CF joined those groups as well. So that was great. And as part of that whole process of doing the call, we involved focus groups. When we got to that final shortlisting of projects that we wanted to review, it was important to get that engagement and to get that feedback, and that was then fed into the final review panel. And we're now at the stage where we've selected 4 projects for funding. We're just working through some of the finer detail with that, and hopefully by the end of the year can make some announcements around that. But, you know, Ed and Connie have just given another example of the CDP call and how very involved the patient groups and the engagement groups were, and how important they were in that as well. So I think we've got some active examples of how we've engaged and how that's influenced, and we want to continue that going forward as we have new initiatives, and also to monitor the progress on the existing initiatives as well. So hopefully that's good, some answers to you. But, you know, from our perspective, what was the response from your CF community representatives when they were asked to talk to LifeArc about their lives with CF?
Yeah, it is very much a partnership, and it is very much two-way. When we ask people to talk about their lived experience with CF, in their day-to-day lives, people are sometimes not so keen to talk about CF. They don't want to necessarily talk to their family, friends, colleagues. They want to try and live with the condition. But given the opportunity and platform to talk to people who can really make a difference, they're unstoppable. They want to talk about their concerns. They want to talk about their worries. They want to talk about their ideas about how things can be improved. So yeah, they're absolutely delighted to be given the opportunity, and as they talk to those who are best positioned to translate those insights into meaningful development.
So, I mean, what did you feel that they get out of the engagement of being involved, and are they aware of what the value of their insights are?
So when we ask people, you know, how they actually feel about given this opportunity, the one word that everybody uses is they feel that it's a real privilege. They feel privileged to be asked to give their insights and experiences in this arena. They find it interesting, it's fascinating, it's inspiring. It's their opportunity to really hopefully improve things for future generations of people living with cystic fibrosis as well. They find it rewarding, it's empowering. All these words, they desperately want to be involved. They're grateful that the organisations such as LifeArc listen and take in, you know, the knowledge and experience that they have from living with the condition. And they recognise that this is a really powerful and positive alliance between the CF Trust and LifeArc. They also want to say that it helps bring hope, and one of the community representatives said the power of hope should never be undervalued, and I think David alluded to that in his opening message as well. They've also spoken about it being a rare act of kindness that they have felt, particularly as they're living with a condition that they often find isolating. To have the opportunity to come together with other people with CF in a safe environment to discuss, you know, the impact of the condition. They really value that opportunity, and I say, you know, to know that that's being taken. The context of living with CF can be taken forward into research.
So how can we ensure that they're kept up to date with how their input is shaping what we're doing?
Well, again, when I let our community representatives know that we were talking today, and if they had any words that I wanted to express on their behalf, they also came back and said, please let us know how it goes. Obviously, I'll be doing that. And I think that's really evident. They want to know what happens when they share these insights. They want to be kept up to date, what is happening in research, who's talking about CF, where the funding is going, what is happening to it, and they want to be kept up to date regularly. They want to see how the story unfolds. They want to know, as you say, the value of their insights and where that led to. Say, in this case, you know, leading to an exemplary funding programme, hopefully moving on world-class research. I don't think they mind what format that comes from. They've said happily to receive that from the Trust, direct from LifeArc as well, whether that's through a social media profile or through newsletters. One of our representatives did actually say he's not on social media. He described himself as miserable. But, you know, happy to receive information, but say, you know, they want the feedback, they want to know what's happening, and they want to know regularly.
Okay, thank you.
At risk of being wrestled off the stage, but we do want to use all our minutes, and as I say, as a reflection of the CF community, we have very little time left. I did share with Katie some of the words, literally the words that were sent to me in preparation for this, and I just wanted to read out some of that feedback to you. So, first one was, I felt quite privileged to share my experience and that there was so much genuine interest on the impact of CF on my life and naturally on others in a similar situation. To know that my small contribution has had a little bit of difference is actually quite rewarding for me personally. I was so humbled that LifeArc were so passionate to try and make a positive difference to those with CF, and just amazing to see two wonderful charities, LifeArc and the CF Trust, working together where they clearly share similar values. It can only prove to be a powerful, positive alliance. I would like to thank LifeArc for choosing to invest in cystic fibrosis and in particular fast-tracking new treatments for lung infections. We desperately need new antibiotics to treat our infections, and to know this is going to happen is very exciting for all those affected by CF. It's only in the last few years, to my knowledge, patients have been invited to have their say about living with CF and the burden of treatments. In the 1980s, if you were involved in research, you were not expected to ask questions or even suggest that it may not be practical or realistic for someone to comply with. It is so amazing that you listen to us, ask our opinions, and act on our thoughts and experiences. I feel very fortunate to be involved with companies such as LifeArc, who clearly want to understand and achieve the best outcomes for those who live with this awful disease. The fact that I am still here to share my experiences and my own personal story over 5 decades of living with CF is not lost on me, and something I appreciate daily. I think it's really evident that we're all in this together, and again, alluding to what David said earlier, I think it is very much teamwork. Thank you.
Thank you.
Thank you very much to Katie and Lorna. So to give our final presentation before the coffee break, I'd like to welcome Professor Andres Floto with an update on the CF Innovation Hub at the University of Cambridge. Over to you.
Thanks very much, everyone. It's a real pleasure to be able to share with you some of the successes that we've had with the Innovation Hub, started in Cambridge a few years ago. As Lucy mentioned, this is a strategic partnership between the CF Trust and the University of Cambridge. And I'm very grateful for the vision and the tenacity of the CF Trust, David Ramsden, and others for imagining what could be achieved with such a partnership. The opportunity to fundraise specifically towards this joint endeavour, to permit the University of Cambridge to match funding for the research. And indeed, thanks to the donations from many individuals and organisations to the CF Trust, to be able to leverage government money to put bricks and mortar in place to develop a CF research facility in Cambridge. So we set out a task of delivering precision medicine for CF. And really, our ambition was to do 2 things: to have Cambridge-centred research focused on 3 overlapping areas of drug discovery, regenerative therapy, and smart technology. But in addition, to support national networks to provide support for UK-based CF researchers in terms of training, sharing of reagents and resources, tech transfer, and thanks to the efforts of Lucy Allen, a UK CF biobank that you may hear about later, or maybe not, but is a really exciting opportunity to undertake a population-level analysis of other genes, that is to say not CFTR, but other genes that may influence how individuals' disease progresses, how they might respond to treatments, and indeed how they may avoid certain side effects of drugs. So we're very excited about that. So we developed an innovation hub as a distributed network across Cambridge with a focus in the CF Research Centre in the new Heart-Lung Research Institute. This is an aerial view of the Cambridge Biomedical Campus that some of you will know. You're all welcome to visit. And this research institute, as I say, built with the help of the funding that the CF Trust provided for the Innovation Hub, which is really next door to Royal Papworth Hospital, which moved from Papworth, west of Cambridge, to be co-located with the other hospitals in Cambridge. But really, the research infrastructure and organisation spread out across the whole of the research ecosystem in Cambridge. And when I mean side by side, I literally mean side by side. This is Papworth on the left, and the Heart Lung Research Institute on the right. And that really, I think, focuses attention of researchers to the importance of actually providing benefit for individuals living with cystic fibrosis, and the opportunity to interact with clinicians, not only doctors, but the whole MDT, to be inspired by them and indeed people with CF in their mission. So within the Heart Lung Research Institute, we're very fortunate to have a large footprint of dedicated wet lab space, including lots of fancy equipment that I'll mention briefly in a little bit. But also co-located with that, an area for our data scientists, computational scientists, structural biologists to sit and interact in a really cross-disciplinary fashion. So the three pillars of research efforts within Cambridge are around drug discovery, both novel antibiotics I'll speak about in a little bit, but also ways in which we might repurpose or redirect existing drugs as anti-inflammatories in cystic fibrosis. And again, we're grateful to collaborations with GSK and Verona around those. Regenerative medicine, both to develop models that could be used to test new drugs in the test tube, but also to begin the foundational work of developing the tools required for cellular therapy as a potential long-term treatment for CF. And finally, smart technology, both in terms of ways in which we can provide actionable intelligence for people with CF to predict future deteriorations, but also to use information to reveal interesting, novel, and impactful biology, and really using it as an engine for research. And again, grateful to Microsoft Research for their ongoing engagement. So what you'll see from the list of principal investigators involved in the centre is a lot of very famous, world-class scientists who prior to this had never done any CF research. Right? Many of them didn't know what CF was. And so one of the tangible outputs of the Innovation Hub was to inspire a group of brilliant scientists to focus on problems that were of importance to the CF community and a legacy after the end of the Innovation Hub funding. So 2018 to 2024, we have a few months left to run. Really, I show you some headline achievements to date, and I'm not going to go through them all. But I hope everyone can appreciate that we've been busy, that there's been a lot of activity and a lot of success. For the scientists in the audience, you'll see there's been a lot of publications in extremely high-profile scientific journals as a proxy for the quality of the research, not least in Nature last week, which attracted some headlines in the papers. But we have, you'll also see that we've achieved in a whole range of different areas, including understanding the biology of infectious disease agents, particularly mycobacteria, and by doing so, to be able to identify targets that could be potentially chosen for novel antimicrobial therapies. We've worked on understanding how the body combats infection normally and identified pathways that may be amenable to host-directed therapy, that is to stimulate the body's own immune system. We've developed a whole range of bacterial genetic methods, and you could argue, well, what's the point of those? They have really transformed the field of pathogen biology and are now being used around the world to inspire and accelerate research. We've made some really important advances in antibiotic discovery, and for those that are interested, I've put the targets in parentheses. But I would argue that our biggest contribution has been understanding why structure-guided antibiotic discovery fails more often than it succeeds, and how we can overcome those to, I'm not going to say trivialize antibiotic discovery, but to make it much more straightforward. And finally, our work on machine learning in collaboration with Mahela van der Schaar from Applied Maths, John Wynn from Microsoft Research, has had a number of important outcomes, not least the development of a predictive algorithm that can allow individuals with CF to recognize that they're going to become unwell in the near future and intervene both in antibiotic and non-antibiotic management strategies. We're very grateful to LifeArc and the MIHR to be funding the clinical trials that are necessary from a licensing perspective for this decision support tool. The trial ACF is now open and up for business and for recruitment. So for those CF physicians wanting to become part of the research effort, please contact me. And for those people with CF who'd like to know more, again, please contact me. We're always happy to chat about that. We've also made some really important discoveries at a fundamental data science area. That is to say, to develop tools to be allowing us to do a number of important analytical activities in CF. So, for example, we've compared the UKCF registry with the Canadian CF registry and identified a number of really interesting areas of policy that may be contributing to differences in outcome. We've developed methods to temporally forecast, that's to say predict for an individual person how they're going to do in the future. We've been able to understand how individuals have not only one potential side effect or complication, but many, and how that interplays. And finally, we hope to be able to use these to not only understand the individual's trajectory, but also to understand decision-making at the level of the CF clinic and in physicians. So I've highlighted in green some of the immediate real-world impacts, and I've mentioned the ACF trial of home monitoring AI predictive algorithms. But we've also had direct impact on international policy. For example, we've influenced the WHO policy around cross-infection, and also in developing new therapeutics against Mycobacterium abscessus, again, a trial that's currently running. So very briefly, just putting some flesh on these bones then, we've been making new antibiotics in two ways. The first is to use artificial intelligence and machine learning to design antibiotics rationally. We've also taken antibiotics that are currently being used, but changed them in a way that we can target them specifically to the infected cells, hopefully reducing side effects. We've understood how bacteria evolve and develop during chronic infection, and this has had really important impacts on our understanding of when to intervene, how to interpret individual bacterial drug susceptibility testings, and understand how certain bacteria become more virulent or aggressive if you allow them to. We've been involved, as I mentioned, in developing the foundational science towards cellular therapy. In slide that hasn't come out very well, we've developed methods to specifically generate ionocytes from iPSCs, from stem cells. The ionocyte is the cell in the lung that has several thousand times more CFTR than the normal ciliated epithelial cell. So these kind of technologies are very exciting since we've identified and can now expand this super hot new cell. And finally, in a slide that hasn't come out very well, I mentioned the forecasting that we've been able to do with machine learning approaches. But in addition to that, we've also been collecting sputum samples to allow us to understand the changes that might trigger the exacerbation and potentially identify novel biomarkers and mechanistic understanding. I'll just spend a couple of moments on the science bit. I have 1 minute, I think, don't I? 1 minute? Yeah. Okay. So what we've done is to leverage the expertise in Cambridge that were one of the pioneers of fragment-based drug discovery, where you reduce the complexity of chemical space and can build from these small Lego blocks of chemicals into a drug-like molecule based on the structure of the protein. And the reason these fail in antibiotics, whereas in fact they're incredibly successful, the company that Tom Blundell span out, Astex, has several billion-dollar selling drugs already in man. The reason it doesn't work in bacteria, in antibiotics, is because we don't understand how the chemicals get in and stay into the bacteria. So what we've been doing in Mycobacterium abscessus and with the help of Gates in tuberculosis is to really define what are the properties of chemicals that allow them to get in, stay in, and not be degraded by the bacteria. And once you have that, you can then guide the chemists into the types of structures that will get in and be useful antibiotics. And very excitingly, we can use this framework to allow generative AI models to imagine new antibiotic species based on the constraints that we've provided. So we've been able to deliver some lead compounds for optimization with industry partners, and we hope that this kind of methodology accelerates antibiotic discovery across both academia and industry for the benefit of all. So I hope I've convinced you that the Innovation Hub in Cambridge has allowed us to engage with world-class researchers, most of which had never worked in CF, to work with people with direct experience of CF. Our steering committee and senior management group has representation from people with CF as well as parents of people with CF. Most, if not all, of the projects have been inspired by and co-created with people with CF, and been able to provide actionable intelligence to improve the lung health of people with CF. And thank you for your attention.
Well, thank you very much, Andres, and thank you also to all of our speakers. We've got our coffee break next. We don't have a Q&A for this session. For those of you here, refreshments are just outside where you came in. You've also got the posters and the sponsor stands. And if you're online, then don't forget to check out the website resources and the online networking forum where you can chat with each other. I'd like to ask all of the early career researchers who are presenting in person in sessions 2 and 3, if you could hang back and meet me at the front of the stage for a quick briefing. Everyone else, we will begin session 2, Symptoms and Complications of CF, at 12:15 UK time. Thank you very much.